Okay, so the next session, it's my pleasure to introduce Arjun from um, Perspectum. He is the Vice President of Strategy in the US, and he's going to be talking a little bit about precision diagnostics. So, Arjun, over to you. Thank you.
Hi, thanks, Bedin. Hi, everyone. Good morning from Boston. It's actually 5 a.m. here, so apologies for any unshaven appearance and a slightly croaky voice. Um, Over the next 15 minutes or so, I'm going to share a few examples of how, at Perspectum, we're looking to integrate our technologies into clinical pathways to enable precision and personalized medicine. So firstly, what does Perspectum do? We develop quantitative objective imaging-derived biomarkers of disease severity. Put simply, we extract information that you cannot just see from an image that, that correlates with that organ's disease state, and we return those biomarkers, some proprietary to us, others that are not, to the physician in the form of a report that they can use to make a decision on treatment choice for their patient. So in essence, a clinical decision support tool. It's all delivered via software as a service, so whereby the raw MRI data is sent to us over the cloud. We analyze it with a semi-automated pipeline, always ensuring that there's a human in the loop for added quality control, unlike some of the other kind of AI digital health solutions out there at the moment. And this is the same workflow we provide both for clinical care in hospital settings or imaging centers, but also for use in pharmaceutical clinical trials. In fact, our biomarkers have been used in, I think, 75 or more past and current trials ranging from phase 1 all the way to phase 3. So we've got a product portfolio, and that spans from the quantitative assessment of chronic liver disease using our flagship liver multiscan service, which provides a proprietary biomarker CT1 of liver disease activity, as well as metrics of liver fat and liver iron, which is being used in clinical practice here in the States, included in society guidelines, etc., through to rare biliary diseases such as primary sclerosing cholangitis, surgical planning for liver cancer, and lastly, the ability to quantify and assess multifactorial diseases such as metabolic disease or long COVID that affect multiple organs in the body. So today I'm going to focus on these latter two use cases and how and why our products Hepatica and CoverScan can enable precision and personalized care in liver cancer and metabolic disease respectively. So first up, liver cancer. Some simple but hard-hitting stats show from multiple sources of global data that not only has the prevalence of liver cancer risen considerably over the past few decades, but also that it has one of the worst prognoses. There are few curative options, but one of these is liver resection surgery, where the tumor or tumors are cut out, often along with significant amounts of liver tissue. Now, this is good in that it can be an effective course of action, but it's challenging using current information available to physicians to predetermine which patients will do well after surgery and which should perhaps be guided to another form of treatment, as can be shown here in the wildly different outcomes in two almost clinically identical patients, one with a smooth experience leaving in 3 days, the other with numerous post-op complications and procedures taking 5 times as long to leave hospital. So we were challenged to address this problem. As I said earlier, our liver multiscan service provides a proprietary biomarker of disease activity as well as liver fat, but we needed to construct a 3D version of our liver multiscan service, segmented via the 8 Quino segments in the liver that surgeons use as landmarks to cut or not cut. It's probably a little bit more complex than that, but surgeons, enabling us to provide regional tissue characterization of disease activity, fat, but also liver volume, and simply slotting into the preoperative workup that patients are already undergoing. So when this was applied retrospectively to a cohort of patients, we saw that, yes, indeed, higher levels of disease activity correlated to worse post-op outcomes. I've not shown that on this slide, but referenced it at the bottom. However, a case example of this to bring it back to the 2 patients from earlier in which traditional data couldn't separate the two: imaging, lower liver volume, higher disease activity, and higher liver fat were the red flags or the only differentiators that could have predicted the difference between liver failure and an early discharge. So this is nice in retrospective, but at Perspective, we tend to ask, what's the so what? How is the information actionable and how does it change patient management? And this is provided in this kind quote from Professor Rees, stating that actually there's a 2-step approach applicable to some of those patients with red livers. And as you can see here, that information enables the procedures such as dual vein embolization to perform this intervention to improve the health of the liver, reducing the disease in it, reducing the fat, and increasing the volume before undergoing the actual surgical intervention. Therefore making that patient a more eligible and appropriate candidate for liver surgery, and therefore resulting in better outcomes. Now, liver resection is one aspect of curative therapy, but actually we want to look further up the pathway. Within the options of treatments available to patients is preoperative chemo, which is used to reduce the size of larger tumors and make it more amenable to treatment. The downside is that it can affect liver health in multiple ways, as shown on the right, in particular focusing on increased inflammation and fat, known as steatohepatitis, and this can therefore complicate liver resection planning. And we wanted to see if imaging could help pinpoint the best time to undergo surgery following chemo. So here, as you can see, we have the ability to assess that short-term increase in inflammation and fat caused by the chemo, increasing liver disease and increasing fat. And therefore, if at 6 weeks the patient had been operated on, they would likely had a worse outcome. But actually, if you wait a couple of weeks, 6 weeks longer, at which point the temporary damage to the liver has receded, almost returned to pre-op levels, the patient is much likely to be a happier one after the operation. And this, I think, is really enabling precision medicine in quite an elegant, but actually quite a simple way. Now, I've shown a bunch of case studies here, but actually our collaborators at Basingstoke Hospital in the UK, to whom a great deal of thanks must be given, have actually conducted a decision-making evaluation of these techniques to validate our early findings using imaging. But actually, given the recurrent, sadly, the recurrent nature of liver cancer, even if you cut it out, often it comes back, as well as the increasing number of precision cancer therapies out there. They included whole genome sequencing as well to see the impact of radiogenomics on the entire patient pathway. So keep your eyes peeled. When the results are published, I think they're going to look really, really good. For the second part of this talk, I'm going to completely shift gears, now for something completely different, as they say. And I'm going to focus on to why the ability to quantify multi-organ health in a single non-contrast scan is important to physicians, as well as other healthcare stakeholders in a metabolic disease, so type 2 diabetes and obesity. Now, unless you've been living under a rock, there's a massive focus on the weight loss drugs at the moment, how they're blowing up due to demand, to Kardashian endorsements, what's their real world efficacy, and how on earth can we manage the costs with such a massive population, along with the general ongoing conversations of how mainly Western healthcare or sick care systems are broken, and that we need to move to early diagnosis and prevention. Now, the value of these drugs in particular is becoming clearer, in my opinion, in that the real clinical impact is on the downstream complications and comorbidities of diabetes and obesity, whether that's improving cardiovascular disease, chronic kidney disease, or fatty liver disease. It doesn't matter. The ability to treat organ-specific comorbidities is vital, since we know that the health consequences of progression in these cases are severe. But focusing on these already medicalized conditions, it also opens up more comfortable conversations around paying for these drugs. An example from the States is that Medicare will now cover those with pre-existing cardiovascular disease, whereas previously their stance was not to cover weight loss at all. In the UK, there are different restrictions on certain sections of the population, and I'm sure in other EU countries, they will have different approaches. But there isn't a uniform way of making these rules. At this point in time, there are only a few marketed options with well-documented limited supply and a massive eligible population. Risk stratifying by disease severity can therefore help make most effective use of that supply in the present. But in the future, as you can see here from this very, very busy slide, please don't squint, you'll ruin your eyesight. This diagram is taken from a publication early this year in The Lancet, showing that there's actually a massive pipeline of these drugs, each with differentiated profiles. Some will be more suitable for people with cardiovascular disease, some for chronic kidney disease, and again, some which have great impact on the liver, for example. In the future, therefore, the question is going to be, how do you choose which incretin to give to which patient? how can you personalize that care based on their underlying organ-related comorbidities? Now, these two questions, how can we answer them? And we believe that that answer is cover scan. It's a single scan and a report providing a balanced scorecard of the health or disease, whichever way you want to look at it, across one's organs, delivered within a couple of hours of the underlying MRI scan, avoiding the need for multiple different tests, some of which can be invasive, some of which require specialist input and can take time to schedule and analyze. So what do these metrics show clinically and why are they important? Well, the metrics and biomarkers in cover scan, many of which have significant clinical evidence behind them, can be used to diagnose or risk stratify many of the most prevalent and impactful conditions that coexist with type 2 diabetes, metabolic syndrome, including COPD, non-alcoholic steatohepatitis, chronic kidney disease, chronic pancreatitis, which is often diagnosed far too late, general organ inflammation and fibrosis, multiple cardiac abnormalities, and last but not least, body composition, which is incredibly important in patients looking to lose weight, but especially who are going to be taking weight loss drugs. It's important for muscle mass preservation, particularly in those who have other subclinical or undiagnosed comorbidities, such as liver disease, for example. Now, when you introduce technology into the ecosystem that's looking to touch as many different specialties as cover scan and to change clinical pathways, it's important that the impact is as positive on as many of these stakeholders as possible. I mean, I think that's pretty obvious. I don't even need to say it. But firstly, and most importantly for patients, technology such as this allows them to take control of their healthcare through an early but also holistic disease diagnosis, streamlining their experience. For pharmaceutical companies in the space, the technology is standardized, centrally analyzed, therefore allowing faster, safer, and more reproducible trials. Additionally, the ability to differentiate one asset from another, as I showed in that previous slide, is going to become more and more important. And the ability to do this in post-market surveillance across multiple indications and really understand the true real-world benefit of these drugs is compelling, not just to pharmaceutical companies actually, but also for regulators. For payers who are looking to manage the, what may be exorbitant costs of these drugs, instead of putting arbitrary rules in place, you can prioritize the most high-risk patients based on their actual clinical picture and enable a better patient experience and downstream better healthcare outcomes. Lastly, but not least, the value to physicians, which is often forgotten. This type of technology allows HCPs to actually affect personalized improvements in their patients' health rather than a blanket one-size-fits-all approach at a stage when that disease course is likely modifiable. And one of the softer aspects is it allows them to engage in truly multidisciplinary care, an area that's normally reserved for cancer MPTs up to now. And talking of cancer, I thought I'd try and bring together those two strands of my talk and end this presentation with a few thoughts on the role of imaging in and the interplay between chronic, often silently progressing disease and cancer. We're seeing both documented as well as anecdotal evidence that the average age of cancer diagnoses in some cancers is getting earlier and earlier. At the same time, we're seeing a concomitant increase in type 2 diabetes, obesity, and metabolic syndrome. Now, correlation, of course, doesn't mean causation, but what is a widely held belief is that conditions such as these lead to chronic inflammation, leading to carcinogenesis and therefore to cancer. At the moment, we use imaging to screen for cancer, diagnose for cancer. However, now that we have the ability to diagnose and monitor these earlier signs and symptoms, it's my strong belief that we need to be scanning for the causes of cancer, not solely because we have the medications now to treat those causes and therefore hopefully to prevent cancers from occurring. I think this is where over a 10 or so year period is where you would really see the impact of technology such as cover scan. Thanks very much for listening, and I think I'm well within time actually, so plenty of time for lots of questions.
Arjun, thank you very much. Fascinating insight into precision diagnostics and the future. A couple of questions for you already. Is it possible to give some examples of the biomarkers that you've identified?
Yes, so the one of the primary tenets on which our technology is based is on T1 mapping, and it's a measure of inflammation and fibrosis in organs. But what we've done is we have identified ways of standardizing that, making it applicable across scanner, vendor, field strength, but also in the liver, for example, correcting it for the presence of iron, which in the past has been a confounder for applying that kind of technique more widely. Some of these challenges don't sound very sexy, but it's one of the reasons that biomarkers such as these have not been widely adopted in cardiac imaging, for example. They're very good, but there's been limited access in the past, and that's one of the things that we're trying to address. So,
And do you think that you will continue to develop more biomarkers as time goes by? Is that your intention?
yes, certainly. I think as you see in cover scan, there's biomarkers of inflammation in the pancreas, in the kidneys, and those are areas that have not really been evaluated or researched as much before. And so those are areas that are very, very interesting, and we've technically validated them, but it's about the clinical validation now. And as I said, keep your eyes peeled for more of that evidence where we're churning it out.
And there's a question about what use of AI you're making. So could you explain that?
Yeah, certainly. So as I said earlier, I think some of our workflow is slightly different from what you might see in an AI tool in radiology that's working in the background on premises. The way we enable AI is essentially to deliver our tools. So we use it for quality control, we use it for image segmentation, we use it for basically enabling a streamlined workflow and getting that report back to the physician. So we call it AI enabled. So it's a little bit of the science as well as the delivery.
Great. And can you just clarify whether the sort of testing that you're doing is solely aimed at healthcare professionals, or do you see an application coming for the citizen or the consumer?
Oh, certainly. I think we're all patients, and I think one of the really important things is engagement. I like a cheeseburger, I like a Coke, and the truth is that unless you see your own health rather than just a number, often your engagement doesn't come in until too late. Primarily healthcare has to be focused clinically around the people who are going to provide that care, but I think there is a real benefit of democratizing and increasing access to the general population of technologies such as this. I don't think we're there yet, and I'm certainly not advocating for population level screening or anything like that. But certainly, I think there's a real opportunity for direct to consumer healthcare. Just improving healthcare literacy. It's a really important aspect. Fantastic. Thank you so much. And thank you again for allowing me on the platform along with a bunch of stellar other speakers. A real privilege. Thank you.
Take care.